Right, next up, and I had to ask Pierre how I pronounce his surname, and I'll get it wrong. So next up we have Professor Pierre Vabres.
Yeah, excellent.
He's been a professor in dermatology since 2005 and an expertise in paediatric dermatology, amongst others. He's one of the leading experts in PROS and has been a principal investigator for clinical trials of drug repurposing within the PIK3CA-related overgrowth spectrum area. He also has extensive knowledge of the effects of alpelisib on those living with PROS, but also on other potential treatments, whether these be surgical or non-surgical. So Pierre, up until recently, was living and working in France, but now lives and works in London, so France's loss is definitely our gain.
Yeah.
So we're delighted to have him here today to share his expertise and his knowledge. So whenever you're ready, over to you.
Thank you very much.
Okay.
So I'm very happy to be invited in this meeting. Thank you, everybody, and thank you, Mansa, for suggesting me to speak. So I think what I will show you, you know it already. I will just try to convey my experience in these different conditions, mainly based in France. So even though I now work in London at the St. Thomas's Hospital, but this is mainly from French patients. So I think that the difficult concept with the PROS is the same as, the story of the blind man and the elephant. Because the story of the elephant and the blind man is what you can see here, is that when you can see the whole animal, and when you are asked what is that animal, if you just have a part of the puzzle, you don't have the whole vision of it. So when you touch the ear, it looks like a carpet. When you touch the tail, it's a rope, and so on. And I think this is what is difficult in PROS. Just an example, the name cloves is such a thing. The name cloves means different things. Congenital lipomas, overgrowth, vascular anomalies, epidermal nevi, spinal anomalies. This is the definition of the acronym, but there are very different manifestations. And they are not all the clove syndrome, or the different types of PROS. Because as you know, there are different types of PROS, depending on what you have. Be it MCAP, macrocephalic capillary malformation, cloves, as we just saw, KTS, Klippel-Trenaunay syndrome, facial infiltrative lipomatosis, fibroadipose overgrowth, also named fibrofatty hyperplasia, sorry about that, or just isolated macrodactyly. So there is really a range of different conditions in the same spectrum, which makes things difficult to assess in clinical trials. And this also explains why there are so many physicians involved in the management of patients with PROS. A few examples here. It's not complete. There are different other specialties or people who are involved in management of patients with PROS. Even for a single problem encountered in PROS, you can have, as we just saw in this very interesting presentation, you can have very different complications. Here you can see that's just for lymphatic and venous anomalies. You can have bleeding, thromboembolism, pain, infection, just the visibility and the cosmetic disability caused by the venous or lymphatic anomaly may be a problem. Oozing, leakage from the malformation can be a problem. One of the reasons why all patients are different can be partly explained by mosaicism, which means that not all cells are affected by the genetic mutation, only some of them, and the genetic mutations can also be different. There are other conditions related to mosaicism, not only PROS but other diseases. And what has been found in the last 10 to 15 years is that they are related to so-called pathways, cellular pathways, which are involved in the functioning of the cells. These pathways can be linked to G proteins, heterotrimeric G proteins, tyrosine kinase receptors, the RAS-MAP kinase pathway, and the pathway that's involved in PROS, the PI3K, AKT, mTOR pathway. And the recent advances in that is that these pathways are involved in cancer. And since they are involved in cancers, there has been an important development of targeted drugs to treat cancers. And in dermatology, for instance, we are very familiar with these drugs, which are BRAF or MEK inhibitors used in the treatment of melanoma. Likewise, sirolimus has been used in the treatment of breast cancer, in the treatment of kidney cancer, and more recently, alpelisib has been initially developed for the treatment of breast cancer. But since the same mutations are found in other mosaic syndromes as in PROS syndrome, they can theoretically also be used. The identification of genetic anomalies are not so old, only a bit more than 10 years ago. And very quickly, it's been possible to, since these drugs were made available, to try them in patients with PROS or other mosaic conditions. So this is a paper that was published in 2018 by a team in Paris, where they state that this provided the first direct evidence that PIK3CA inhibition is a robust and effective therapeutic strategy that can markedly improve the outcome of PROS patients. At that time, they had only treated 20 patients, and it was very difficult to know if this was true. They claimed that the results were impressive, yet it was 5 years ago, and more studies were needed, and we just saw the current EPIC-P2 trial that has recently been performed. And definitely, it is really important to have clinical trials for PROS patients or other patients with rare diseases, because you don't have enough scientific evidence from just case studies or case series. And definitely, what we should be aiming at is the ability to reach, to perform randomized controlled trials, to reach better results and better quality of evidence for the drugs to be approved by the FDA or the EMA. And the difficulty in these studies is to find the right endpoints, the proper endpoints to be studied. For instance, here you have a few endpoints that can be found that can be used in studies. I'm sorry. And for instance, in the EPIC-P2 trial, what has been used is the volume of the vascular anomalies determined by MRI. I think this is a helpful endpoint to study, but it's not the only one, and there are many others that could be used. Maybe we should focus on bleeding, oozing, vascular anomalies, on thromboembolism. Maybe we can assess the volume only by photograph imaging, so there are many ways. And I think what would be really important when we develop new trials is to use patient-reported outcome. I don't know why the slides have their own lives. So definitely quality of life, pain and functional limitations are, in my opinion, major endpoints to be assessed to see if a drug is really helpful for patients. This table shows you that it's not so easy to move from cancer to rare conditions such as PROS when using drugs initially developed for cancer but repurposed for other conditions. Because you don't use the same outcome measure, you don't use the same endpoints in the two populations. For instance, when you have to determine a primary outcome in cancer, it's usually overall survival or progression-free survival. But in disease such as PROS, it's not, usually not a lethal condition. And there are these various other endpoints that you should assess. As a secondary outcome, patient-reported outcomes such as quality of life are, in my opinion, important. These are not the same patients. Most patients with PROS who need treatment are children. And the endpoint is not determined at the same time. It's not just a few months as in trials for cancer, even though it's difficult to perform long studies. But the best studies would take years to determine in children what is really the outcome of treatments. And the duration of treatment, so far we don't know. How long should we treat patients? Is it lifelong? Is it just during childhood? It remains to be determined. The drug dosage is a question that has not been thoroughly assessed. We don't really know if what is the proper drug dosage for PROS as compared to cancer. And adverse events, you can't see the same thing after 6 months or after 3 years, 4 years, 5 years. And this is why it's really important to have long-term follow-up, because this is when we see if there really are problems with the drug, and not in 6 months. It's not enough. Targeted drugs. Back in 2018, this paper was a retrospective study by our colleagues from Brussels in Belgium, using sirolimus in patients with different types of vascular anomalies, but in which 6 of them carried PIK3CA mutations. And what they had found is that all patients had improvement of symptoms and quality of life. So definitely sirolimus is a drug that's helpful for quality of life, which has been difficult to assess later, but it's definitely something where there is improvement. Regarding the malformation itself and the imaging of the malformation, it was not clear whether it was helpful, because in some patients we had progression, improvements, or it remained stable. So it's difficult to really know the effect on the volume of the vascular anomalies, but for quality of life improvement, it was something that was helpful. An example here of reduction of oozing and bleeding in a patient with an extensive lymphatic, venous or lymphatic malformation. There seems to be an improvement in pain, definitely here, and maybe an improvement on the coagulopathy, on the thromboembolic, the risk for thromboembolism in these patients because of improvement of D-dimer levels. This is another study a French nationwide study that was published 2 years ago in patients with venous or lymphatic anomalies treated with, it was a prospective study, treated with sirolimus. It's a bit complex here, but the end results were that it didn't do much on the volume of the vascular anomalies, but once again, there was definitely an improvement in the pain and the quality of life of these patients. Some of them carried PIK3CA mutations. This is a study that we performed together with Professor Sample and Professor Biesecker a few years ago, again on sirolimus in PIK3CA positive patients. Most of them were children under the age of 16. And the results that the endpoint was the overgrowth, the volume of not only the vascular malformation, but the whole overgrowth. And there was definitely a slight improvement in these patients. We were surprised that there were quite a high number of adverse events with sirolimus, which is not always what is reported in other studies. What about alpelisib? Alpelisib, what about several papers have been published where they have used alpelisib in patients with PROS, different types of PROS. The problem is it was never performed as part of a clinical trial. So it's quite difficult to determine if there is or if there is not an improvement, and if this improvement is real. Here are a few results from patients of mine. This young man, 31 years old when we started the drug, he had an extensive overgrowth and lymphatic malformation of his right leg. He had been treated with sirolimus previously, which he didn't tolerate very well. And with alpelisib, initially there was a notable improvement in the volume of his leg. It decreased of a few centimeters, the circumference. But as you can see here, after 3 to 6 months, there was no more improvement. The patient was very happy with that and didn't want us to withdraw the drug. So we kept treating him. He developed diabetes, but it was possible to decrease the dosage and to treat him with metformin. So eventually it was fine. It was not a problem. The second patient treated with alpelisib was this young girl, 3 years old, with voluminous lymphatic malformation of her foot, as you can see here, and this time there was absolutely no response of the volume. We don't know what would have been the outcome, the spontaneous evolution without the drug, but it was quite disappointing to see these results. She's been treated for quite a while now, even though there was not a real improvement. These patients have been part of the study that has just been published last summer, EPIC-P1, which was a retrospective chart review of these patients. And the results are as follows. 6 months after drug initiation, only about 1/3 of patients had reached the primary endpoint. The primary endpoint was that reduction in 20% of the volume of target lesions. which is not that much. It remains that 80% of the lesion remains, and only about 1/3 of patients manage to have that response. So definitely it helps, but it's not a miracle drug. Adverse events were quite tolerable. Here, hyperglycemia and after ulcers, and were not very common in these patients. What's interesting to look at is this figure. Maybe it's not very easy to read, but these are all the secondary endpoints which have improved in patients. And this illustrates the difficulty to find the good endpoint to assess in these patients. Here you have fatigue, coagulopathy, asymmetry, lipomatosis, scoliosis, overgrowth. There are definitely many different types of endpoints that you can assess in these studies, and the difficulty to find the right one. So there might have been an improvement in the patients, but it's very, very, very difficult to compare patients between them. Nevertheless, the drug has been approved by the FDA last year, before the results were published. In spite of this quite modest improvement, in my opinion. A few years ago, we performed a clinical trial, once again with Professor Sample, with another inhibitor of the PI3 kinase, which was tazolizumab, developed by another company, also for breast cancer initially, and we treated a few patients. We had designed the study as a stepwise increase of the dosage, because we didn't know the right dosage. And we sought to assess the safety of the drug, not the efficacy. The problem is that after a few patients who were treated and were happy with the treatment, as this young woman who had a voluminous vascular malformation of the pelvis with permanent bleeding, resulting in severe anemia, which resolved very quickly on the drug. She stopped bleeding, and her hemoglobin increased. And when the drug was stopped, once again, hemoglobin decreased again. So even though the drug was successful in some patients, in some others, we observed severe adverse events. One had colitis, the other meningitis. So we have to withdraw, not only to withdraw the drug, but to stop the trial after only 16 patients. So this shows that it is really, really important that patients are treated as part of clinical trials, because they are properly monitored, and if there is a problem, we know that we can stop the drug. And I think it's way safer to be included in a clinical trial than to be treated outside of a clinical trial, if possible. In patients with MCAP syndrome, there is a study in France that has just been completed, still with alpelisib, and in which there is assessment of neurological anomalies and intellectual impairment in these patients. I don't know the results. I know that all patients have been included so far, but I don't know the efficacy of the drug. I would like to say a few words about 2 points in the management of PROS. The first one is the issue of the risk of cancer in PROS. Since PIK3CA is an oncogene, theoretically it could be a predisposition to cancers. And indeed, in the literature, it's advised, for instance, on the Gene Reviews website, to perform abdominal imaging in children with PROS. There are other overgrowth syndromes, a few examples here: Beckwith-Wiedemann syndrome, Soto syndrome, Simpson syndrome, Perlman syndrome, where there is an increase of abdominal tumors. Is it the case in PROS? Nobody knew, but we performed a retrospective study which was published last summer again. And what we saw in our study is that we studied 267 patients with confirmed PIK3CA mutations. Only 6 developed a cancer, which is about 2%. And as you can see here, the cumulative probability of developing a cancer remains quite low throughout life, only about 5%. In the study of the literature, we found few cases of Wilms tumor, which is the kidney tumor that occurs in children, in these other conditions, and which is very low, and it's not at all the rate of cancers in other syndromes. So there has been a confusion between PROS and other overgrowth syndromes where there is a risk, whereas in PROS there's not such a risk. So this risk is low and doesn't warrant systematic, routine abdominal imaging. Here you have the results of our cohort on what's been published in the literature with patients with PIK3CA mutations. So definitely Wilms tumor exists, but it's very rare. And when it develops, it's usually quite early in life. Only one patient in our cohort had Wilms tumor, and she had the first signs at the age of 2 or 3, but it was not an aggressive tumor. It's also called nephrogenic rests. And she was treated only at the age of 9 years. The diagnosis was made several years ago. So definitely it was not an aggressive tumor. Nevertheless, this is very rare in close patients. What about other tumors? In our series, we found an ovarian tumor in an adolescent, and all of the tumors were found in adults. But it's not clear whether they are related or not to PROS. Probably not, because we found the variant only we found the variant, the PIK3CA variant, in tumoral tissue only in one patient here, in this young patient. So there is no evidence that the cancer was related to PROS, which means that the recommendations that you can sometimes read are not correct for PROS. And a study we haven't published yet is to expand the PIK3R1 phenotype. What's PIK3R1? It's actually the cousin of PIK3CA. These are genes that encode molecules that work together. PIK3CA encodes the catalytic subunit of the PI3 kinase, whereas PIK3R1 encodes the regulatory subunit. And it's been found a few years ago that some patients were affected with mutations in PIK3CA with a similar phenotype. So we reanalyzed a series of patients. We had performed PIK3CA sequencing in more than 600 patients. About half of them were positive. And in those negative, we performed PIK3CA sequencing and found a variant only in 15 patients. So it is a cause of PROS, but it is a rare one. It's 20 times less common than PIK3CA mutations. Here you can see the mutations, which are activating ones. And here is a summary of the phenotype. These patients had segmental overgrowth and as vascular anomalies, mainly capillary malformations. And they also had not only overgrowth, but also hypoplasia in one of them. Varicose veins were very common. Venous dilation, dysplasia were very common. Pigmentary anomalies were found as well. So we don't know yet if it's really different from prose, but it really looks the same. This is an old surgical paper about these so prose is not only related to PIK3CA, it also can be related to PIK3R1. Maybe the name could change a bit, not only PIK3CA related overgrowth spectrum, but PI3K related overgrowth spectrum. So thank you for your attention. I would like to thank my team in Dijon, back in France, for all the work that we still keep doing together.